It's a pleasure to be here today. I want to thank Axel and David for organizing this session and for their kind invitation. So what I thought I would do as the last session of today is to briefly discuss some of the important GI inherited cancer syndromes that I think all of us need to know about, partially for the importance of our patients who we are treating. As Dr. Siegel pointed out, this is becoming more and more relevant as we have more and more targeted therapies for some of the inherited cancer syndrome-associated tumors, but also for at-risk family members where we can actually have impact in terms of cancer prevention. I have no disclosures to declare. So over the last 15 or so years, what we have come to realize that larger than we thought of all cancers are hereditary, meaning that even in common cancers such as stomach, colorectal, pancreas, up to 20 to 30% of patients have familial clustering, some of which may be mediated by genetic susceptibility. And our research, including linkage studies and then subsequent candidate gene studies and now next-gen studies, have implicated a number of cancer susceptibility genes associated with many different cancer syndromes. Obviously, the one that has been in the news the most this week is hereditary breast ovarian cancer, with Angelina Jolie having had her ovaries appropriately removed for ovarian cancer risk reduction. We tend to hear a lot less about hereditary GI cancer syndromes, but I think they're just as important and often are not identified. So what I would like to do is review GI cancer syndromes, including colorectal cancer predisposition syndromes, gastric cancer associated predisposition syndromes, and then finally familial pancreatic cancers. So starting with colorectal cancer, we know that about 3% of all patients with colorectal cancer have Lynch syndrome, and patients with Lynch, also called HMP, have a very high risk of developing colorectal cancer, about a 70% lifetime risk of colorectal cancer. Patients with classic familial adenomatous polyposis have essentially 100% risk of colorectal cancer by about age 40 to 45, and this is compared to the general population risk of about 5%. Now, Lynch syndrome is an autosomal dominant disease. It's associated with early onset of colorectal cancer. The average age at diagnosis is 43, 44. Oftentimes, these patients present with synchronous colon tumors, and it tends to have a right-sided colon predominance. As Dr. Siegel pointed out, oftentimes these tumors are associated with tumor-infiltrating lymphocytes, and we hope that immunotherapy can be used to take advantage of this aspect of it. And in addition to colorectal cancer, these patients are at a high risk of endometrial cancer, ovarian cancer, stomach, urinary tract, small bowel, sebaceous tumors, and even brain tumors. The 5 genes now, and EpCAM, the new one on the list, has recently been implicated, that are known to be causative of Lynch syndrome are MLH1, MSH2, MSH6, PMS2, and EpCAM, which is just upstream of MSH2. The majority of mutation carriers have either an MLH1 or an MSH2 mutation. However, about 5 to 10% probably have PMS2, and another 10% have MSH6 mutations. These are 2 more recent ones that we have just started to test for clinically over the last probably 10 years or so. Now, Lynch syndrome is due to a genetic defect in the mismatch repair gene, which causes the mismatch repair protein to function abnormally. And essentially, it introduces DNA replication errors that are essentially not corrected. And the hallmark of this is microsatellite instability. So we all have microsatellites throughout our entire genome, and these microsatellites are essentially just short, tandemly repeated DNA sequences. However, if you have a mismatch repair gene abnormality, these microsatellites are very prone to genetic changes and genetic alterations, and these can introduce different length in the microsatellites, so you're essentially adding extra bases or deleting some bases. And this is really the hallmark of Lynch syndrome-associated tumors. The way to diagnose Lynch syndrome is to start with tumor testing, and this really goes back to basics. You can either start with microsatellite instability testing through a PCR analysis, or you can do immunohistochemical staining for the mismatch repair genes. Our preferred method at MSKCC is to do IHC as a first-line screen for Lynch syndrome because it can direct your germline testing. So if you have absence of, for example, an MLH1 and a PMS2 protein in the tumor, that would make you target MLH1 for germline genetic testing, and I would think that your gene mutation would be in the MLH1 gene. So I think it's a little bit more helpful in terms of IHC as opposed to MSI, where you don't know which gene may be implicated. The concordance between these two tests is quite high. Now, who should be screened for Lynch syndrome? And I think it's important to know that these criteria are ever changing. So originally, we had the Amsterdam criteria, the 3-2-1 rule, where you had to have 3 family members with a Lynch-associated cancer and 2 first-degree relatives with 1 person under the age of 50 at diagnosis. But 50% of our Lynch patients actually do not meet Amsterdam criteria. So clearly, that's just not a sensitive screening test. So in 2004, the Bethesda criteria were published, and that stated that patients with colon cancer under the age of 50 should be screened for Lynch, and then if there was a stronger family history of Lynch-associated tumors. These guidelines have been adapted to include endometrial cancer at this point, and then recently the NCCN guidelines have been updated to recommend IHC or MSI screening for all patients with colorectal cancer or for all patients under the age of 70 with colorectal cancer. And we have just expanded our guidelines at our institution, and we're doing reflex IHC testing on all patients with colorectal cancer under the age of 70. The other criteria clearly still apply, so if there's a strong family history, then IHC or MSI should be done. Now, what are the next steps? So once a mismatch repair deficient tumor is noted, then generally they're sent for genetic counseling, genetic testing, and if Lynch syndrome is identified, then these patients are at a high risk of subsequent malignancies. The lifetime risk, again, of colon cancer is about 70%, endometrial cancer 40 to 60%, but the other malignancies are not to be neglected, including ovarian up to 12%, especially in MSH2 mutation carriers, urinary tract cancer, biliary tract cancer, and then more recent data published by Faye Castrinas, who was at Dana-Farber and currently at Columbia, suggesting that there's also a link to pancreatic cancer, and in fact, about an 8-fold increased risk of pancreas cancer in patients with Lynch syndrome. Now, as we know, there's no good screening for Lynch syndrome, although we do have a number of registries throughout the country for patients who are at a higher risk, including our own at MSKCC. But what has also become very apparent, and this is Karen Liu's study from MD Anderson, is that in women, the Lynch syndrome can present a little bit differently. So what she did in a very elegant study, she took 117 women with Lynch syndrome who had both endometrial cancer and colorectal cancer. And in about 14% of patients, they presented with their endometrial and colorectal cancer simultaneously. However, in the other about 100 women, 50% actually presented with their endometrial first, 50% with their colorectal cancer first. So as we see these patients, I think it's very important to recognize that especially in women, a diagnosis of early onset ovarian cancer or early onset endometrial cancer should prompt further genetic analysis. So what do we do for our patients with Lynch syndrome? Well, colonoscopy works. This is an old but good study. It's 15 years old now, and the screening frequency that was done in this study was actually a Q2 to 3 years. The guidelines now are Q1 to 2 year colonoscopy for our patients. At Memorial, we tend to stick to the conservative side of that, and we do annual colonoscopies in our proven mutation carriers, and this does save lives. Other risk reduction strategies are not as well, I guess the research behind it is not as well documented, and there's not as strong evidence. So in colorectal cancer, other than colonoscopy, you can have risk-reducing colectomy. I have to say that the majority of patients who choose, for example, a subtotal colectomy are patients who already have a cancer diagnosis and are going in for a surgery with a known Lynch diagnosis. It's rare for patients to undergo subtotal colectomy when they do not have a cancer diagnosis within the context of Lynch syndrome. Chemoprevention options, as Dr. Ilsen alluded to, there was a very nice study in Lancet by John Byrne led from the UK, where they randomized patients to 600 milligrams of aspirin versus no aspirin. These were all germline mutation carriers for Lynch, and showed over the long run that in fact there is a benefit with about a 40 to 50% risk reduction in colorectal cancer risk over if you take the aspirin for at least 2 years. The controversy with the study is that the aspirin that was used is a very, very high dose, obviously 600, even though their study didn't suggest that many side effects. We are hesitant to give such high doses of aspirin to our Lynch patients, but we do recommend it. I usually start with a baby aspirin and may titrate up if the patient tolerates it. There is a plan for a CAPS-3 study, which is a non-inferiority study in over 3,000 Lynch patients, randomizing them to 100, 300, or 600 of aspirin. Obviously, that will take a long time for that study to evolve and provide us with good data. For gastric cancer screening, we start around age 30 to 35, every 2 to 4 years. Upper endoscopy is recommended. No proven benefit, but we do this for our patients. For endometrial and ovary, the true recommendation is to have the uterus and the ovaries removed after childbearing is complete, around age 40-ish or so, for prevention of these cancers, as the other screening modalities don't seem to work in a way that has been proven. For urinary tract, there's some evidence that the patients who are probably at highest risk are men, especially who smoke, and who are MSH2 mutation carriers. So some of the European groups suggest that we should only screen those patients. Currently, the recommendations have moved away from urine cytology to urinalysis every 1 to 2 years, starting at age 25 to 35. So what's the emerging data on Lynch? I think one of the most important data that's coming out are these genotype-phenotype correlations. So not all mutations are created equal. For example, what this study shows here is that MSH6 mutation carriers seem to have a much lower risk of colorectal cancer than MLH1 and MSH2 carriers. And in fact, their age at onset of colorectal cancer tends to be later than the age 40 that we are used to seeing. In endometrial cancer risk, MSH6 mutation carriers have a much higher risk than MLH1 or MSH2 carriers. So I think some of the screening and recommendations for when to do a TAH-BSO, for example, may change based upon what mutation one carries. There's further data coming out on PMS2. We were part of a large multi-center study of PMS2 carriers. It's a very rare mutation. Through, I think, 15 different centers from the US, we have put together over 170 families with PMS2 mutations, and that study is currently in press. At the end, the data are not so convincing that the risk of colorectal cancer is lower in PMS2 than other mutation carriers, but I think it's important to get this data out there so we know what to do with these patients. EpCAM, the risks are really not known at this point. And then last but not least, I think the other associated cancers, I mentioned pancreas cancer. There were 2 studies, one implicating a slightly higher risk of prostate cancer and another one implicating a slightly higher risk of breast cancer in these patients. But those risks for both prostate and breast were about a 2-fold increase in risk, and it's really not enough to change or drive a change in our screening recommendations. So we really still base those recommendations on other family history, not necessarily on whether they have Lynch or not. So Lynch is the most common hereditary colon cancer susceptibility syndrome. I'll briefly run over the familial adenomatous polyposis syndrome. Accounts for probably 1% of all colorectal cancers. In its classical form, this is what you see in the colon. The colon is basically carpeted with adenomatous polyps, essentially 100% penetrance if the colon is not removed. However, there are also other cancers that are associated with this: duodenal, periampullary, small bowel, pancreas, thyroid, and some others. What we do for these, for FAP carriers, is we start sigmoidoscopy, colonoscopy, essentially by age 10. We are starting to test these children that have parents with FAP at a very early age, even age 1 or 2, because they do have an increased risk of hepatoblastoma as well. And then the recommendation is really prophylactic colectomy, late teens, early 20s, sometimes based on the amount of of polyps in the colon. And this does save lives. Other screening that we do for our FAP patients is upper GI screening, questionable better screening for hepatoblastoma, but ultrasound or thyroid cancer is actually used for, or whether it helps to diagnose things at an earlier stage. We usually tend to still do it in our clinics. Now, what's also interesting is that the genotype-phenotype correlations are very, very tight in FAP. So for example, if you have a mutation in this part of the gene, of the APC gene, then you're at a much higher risk of developing, for example, desmoid tumors. And in fact, if you have mutations in the 3' or the 5' end of the APC gene, then you have a totally different phenotype, which is called attenuated FAP. And attenuated FAP is generally considered as FAP that has less than 100 adenomatous polyps. Usually the colon cancer onset is much later in the 50s, and their extracolonic manifestations are much less drastic. They usually don't get the desmoid tumors and don't get the upper GI tumors as well. In patients that have an AFAP-like phenotype clinically, but do not have an APC mutation, we often test for something called MYH, and MYH is very interesting because it's not autosomal dominant, it's autosomal recessive, so you have to have biallelic MYH mutations to have the disease. So if someone presents you with less than 100 polyps, is APC negative, and has no history of colorectal cancer, you should really think about the possibility of an MYH mutation, because with autosomal recessive, you don't necessarily have to have the family history. And then last but not least, through next-gen sequencing, a number of new genes have been discovered, including POL and POLD1. POLD1 is associated with polyposis as well as probably endometrial cancer risk. POL probably more just adenomas and colon cancer risk, but really these syndromes are very new and we are still defining them. Moving on to hereditary GI, or gastric cancers rather. So the one that I really want to focus on today is hereditary diffuse gastric cancers. All the other ones that are listed on this table are really associated with more intestinal subtype. So hereditary diffuse gastric cancer was first described clinically in 1964, and this is a very large family of Maori descent. And what you see is over 25 family members affected with gastric cancer, clearly in an autosomal dominant way. And in fact, you can see that this gentleman unfortunately passed away of gastric cancer at the age of 14. What we have come to realize over the years is that the tumor suppressor gene that's responsible for this is CDH1, which encodes E-cadherin. E-cadherin, when it's mutated or not functioning properly, causes uncontrolled cell proliferation. So the people to consider for CDH1 testing, I think the most important to remember is anyone with really early onset diffuse gastric cancer, so under the age of 40. Also patients with obviously a family history of diffuse gastric cancer or lobular breast cancer, which is also a component of this syndrome. The lifetime risk of gastric cancer is very high, although there may be some ascertainment bias in the early studies. We think that the risk is as high as 70–80% in men and in women. In women, lobular breast cancer risk is about 40% by age 80, and increased surveillance through breast MRIs is definitely encouraged for these women. For the management of gastric cancer and prophylaxis, the recommendation is really a prophylactic gastrectomy, and that seems obviously kind of drastic, but I'll show you why. So these are the gastrectomy samples of 8 patients who are known CDH1 mutation carriers, and they went in for routine endoscopy prior to their resection with many 30 to 35 biopsies taken from random samples of their stomach. And upon resection of their stomach, what you see here are these little yellow dots, which represent multifocal signet ring cells, which is what's associated with diffuse gastric cancer. So obviously it's impossible to screen for this endoscopically, so the recommendations in these patients is gastrectomy. And then last but not least, pancreas cancer. I just wanted to mention it because it's an emerging topic. About 10% of pancreas cancers are hereditary. About 20 or 25% have a familial clustering. And And in fact, the familial pancreatic cancer is defined as someone with greater than 2 first-degree relatives of pancreatic cancer without a known genetic defect. I just wanted to give you a sample of such a family. What you see here are 5 individuals who have been affected by pancreas cancer. And in fact, I'll show you the genes that we tested for, but in this individual, we tested for many, many different genes that were all negative. And unfortunately, still the majority of our purely familial panc cases are negative for the genes that we know about today. And in fact, the gentleman that I ended up seeing was this 34-year-old unaffected, and he was asking about his risk. And unfortunately, with such a strong family history, he probably has at least a 10-fold increased risk of pancreas cancer over the general population. These are the patients that we actually enroll in our pancreatic cancer registry here and do investigational screening. Here we use MRIs. Hasn't been proven to be efficacious, but under Dr. Kurtz, there is a study going on with this. Some of the syndromes that we think about in hereditary pancreas cancer are hereditary breast ovarian cancer syndrome, probably a 7% lifetime risk of pancreas cancer in BRCA2, 3% lifetime risk in BRCA1, Lynch syndrome I already mentioned, and then some of the other genes that are sort of newcomers are PALB2 associated with not just pancreatic cancer susceptibility, but also breast cancer susceptibility, so we tend to test for these. Some of our recent data, we pulled our data from the last 3 years, 2011 to 2014, and in our families that have been referred to us, or patients who have been referred with pancreatic cancer, about 15% had a mutation, with 50% of them having a BRCA2 mutation specifically. So last but not least, there's a lot of new research going on with next-gen sequencing. New genes are being discovered and implicated. And next-gen sequencing has also made available what's called multi-gene testing, and there are a number of different companies that provide such multi-gene testing for cancer susceptibility. I think what we need to be careful of is that if you test someone for this, there's probably a 20 to 30% chance of having not a positive or a negative result, but coming up with a variant of unknown significance, where we don't really know what to do with that patient and what to do with that data. We don't know if that genetic change is actually causative of your cancer or not. So I think you need to really weigh the risks and benefits of such multi-gene panels very carefully prior to sending it off. And then last but not least, I think there are continued barriers to genetic testing. I think in GI, the one that I find the most difficult is that so many times our patients have advanced disease and they just don't make it into genetics. We've tried to account for that and try to help patients get seen in clinic or during their chemotherapy sessions so that we can at least get them tested and hopefully if there's a mutation, screen their families appropriately. And obviously there's a lot of new data coming out with next-gen sequencing, and we hope to identify more families and more syndromes to prevent cancer in at-risk family members. Thank you.